Lecture 3 Articulators. This presentation has been prepared by Musayev Emin, Docent of Ortopedic Dentistry Department. Articulator definition. An articulator may be defined as a mechanical device that represents the temporomandibular joint and jaw members to which maxillary and mandibular castes may be attached to stimulate jaw movement. Mandibular movements. Basic. Excursion of the mandible in three directions. Downward movement, opening of the mouth. Forward movement, protrusive. Lateral movements, sideways. Basic components of an articulator. Upper member represent maxilla. Lower member represent mandible. Condylar tract, condylar element, vertical rod, incisal pin, incisal guide table. Occlusal curves of teeth. The bone-will triangle. The mandible adapts to a fourth equilateral triangle. Facile bilateral symmetry of mandibular arch. Curve of Wilson. In coronal plane, posterior view, transverse. Sphere of Monson. Monson formulates the spherical theory as three-dimensional occlusion model, combining curve of Spee and curve of Wilson. Devices that increase motion of mandible. Occludators, articulators. Articulators which have middle establishment. A. Articulators are which middle establishment of arterial veins. 2. Articulators with a middle establishment of inclination of arterial and chisel veins. 3. Articulators with the middle establishment of occlusal curves. Articulators are with individual establishment, arterial articulators, non-arterial articulators. Purposes. To hold the maxillary and mandibular castes in a determined fixed relationship, mounting of dental castes for diagnosis, treatment, planning and patient presentation, to simulate the jaw movement like opening and closing, fabrication of occlusal surfaces for dental restoration, arrangement of artificial teeth for the complete and removable partial denture. Uses. To diagnose the state of occlusion in both the natural and artificial dentition. To plan the dental procedures based on the relationship between opposing natural and artificial teeth. Evaluation of the possibility of balance occlusion. To aid in the fabrication of restorations and prosthodontics replacements, to correct and modify complete restorations, to arrange artificial teeth. Requirements. Two types of requirements. A. Minimal requirements. B. Additional requirements. Minimal requirements. They are necessary for the fabrication of complete denture to the patient-centric position. They are: first, it must be accurately maintain the correct horizontal and vertical relationship of the patient's castes. The castes should be easily removable and attachable to the articulator without losing their correct horizontal and vertical relationship. The articulator should have an incisal guide pin with a positive stop that is adjustable and calibrated. The articulator should be able to open and close in a angle-like fashion. The articulator should accept a face bow transfer utilizing an anterior reference point. The construction should be accurate, rigid and of non-corrosive material. The moving parts should move freely without any friction. The non-moving parts should be of a rigid construction. The design should be such that there is adequate distance between the upper and lower members. The articulator should be stable on the laboratory bench and not too bulky and heavy. Additional requirements. The condylar guides should allow right lateral, left lateral and protrusive movement. The condylar guides should be adjustable horizontally. The articulator should have provision for adjustment of bayonet movement. The incisal guide table should be mechanical table that can be adjusted in the sagittal and frontal planes, or a table that can be customized with auto polymerizing resin or by grinding. Advantages. Properly mounted casts allow the operator to better visualize the patient's occlusion, especially from lingual view. Patient cooperation isn't a factor when using an articulator once appropriate interocclusal records are obtained from the patient. It reduces the chair time, patient appointment time. The refinement of complete denture occlusion in the mouth is extremely difficult because of shifting denture bases and recency of the supporting teeth. Interocclusal records can be obtained and complete denture occlusion can be refined outside the mouth on an articulator. More procedures can be delegated to auxiliary personnel when utilizing an articulator for development of patient's occlusion. The patient's saliva, tongue, and cheeks aren't factors when using an articulator. Limitations. Metal plastic articulators show errors in tooling manufacture. It not exactly simulates the intraborder and functional movements of the mandible. Errors in jaw relation procedure are reproduced as errors in the denture occlusion. Articulators don't have any provision to indicate or correct these errors. Classification of articulators. Several bases of classification of articulator were proposed. Some of them are as follows: based on the instrument function, based on the adjustability of the articulator, based on the location of condylar elements. Based on the adjustability, three types: A. Non-adjustable, B. Semi-adjustable, C. Fully adjustable. Non-adjustable: an articulator that doesn't allow adjustment to replicate mandibular movements, can open and close in a fixed horizontal axis, have a fixed condylar path. Semi-adjustable: an articulator that allows adjustment to replicate average mandibular movements, have adjustable horizontal condylar paths, adjustable lateral condylar paths, adjustable incisal guide table, and adjustable intercondylar distance. Fully adjustable: an articulator that allows replication of three-dimensional movement of recorded mandibular motion, capable of being adjusted to follow the mandibular movement in all directions, based on the location of the condyle, archon, non-archon. Based on instrument function. At the International Prosthodontics Workshop on Complete Denture Occlusion at the University of Michigan of 1972, the articulators classified based on instrument capability, intent, recording procedure, and record acceptance. Consist 4 classes. Class 1, a simple holding instrument capable of accepting a single static registration. Vertical motion is possible. Non-adjustable articulator. Class 2, this articulator permits horizontal and vertical movements, but they don't orient the movement to TMG by a phase ball. They are type A, B, C, 3 types. Upper member, triangular frame, vertical rod with thumb screw, 2 condylar elements. Lower member, shaped frame with horizontal and vertical arm. Horizontal arm is triangular and its apex contains incisal guide table. Vertical arm is rectangular, containing condylar guidance slot at upper portion. Type A. Instruments in this class permit eccentric motion based on average and will not permit phase ball transfer. The condyles are on the lower member of articulator, based on Bounville's triangle. Gritman articulator, the Giese adaptable and Giese simplex articulators. In 1910, but apparently it was beyond the technical ability and finances of most dentists. For this reason, the Giese simplex was introduced as a mean value articulator in 1940. Type B. Instruments in this class permit eccentric motion based on arbitrary theory of motion and will not accept a phase ball transfer based on spheric theory of occlusion. It's Monson's articulator. Spherical theory articulator by Monson. Maxillomandibular instrument designed in 1980 by George Monson, arose from concepts of Monson and a German anatomist Graf von Spee. Type C. Instruments in this class permit eccentric motion based on engraved records obtained from the patient and will not accept a phase ball transfer. House's articulator. Class 3. The articulator permit horizontal and vertical motion and they don't accept phase ball transfer, but this facility is limited. They are type A, type B. Incisal guide table contain very short cylinder whose upper surface is concave. Vertical rod should rest on the center of the incisal guide table during articulation. Condylar guidance represented by a slot condylar track. Condylar element of the upper member passes through this track. A spring is mounted within this track to establish the condylar elements. Vertical rod or incisal pin helps to keep a fixed distance between the upper and lower member at anterior end. The pointed tip of vertical rod should rest on the center of incisal guide during articulation. Incisal guide pin present at the midpoint of vertical rod. The incisal edge of maxillary incisors at the mid-line of the occlusal rim should touch the tip of incisal pin during articulation. It presents the anterior reference point. Type A. This accepts a phase ball transfer and the protrusive intraocclusal record. Hanau articulator, Hanau H2 articulator, Bergstrom articulator, Hanau model H2 series, the Dentatus arrow articulator, Dentatus arrow articulator. Type B. Instrument in this class accept a phasebow transfer, protrusive intraocclusal records, and some lateral intraocclusal records. Tribute articulator, tripod articulator, new articulator, Hanau, Teledyne articulator, and Penadent articulator by Gizzi, Stoneberry, Del Pietro, Richard Bew and James Janik, Richard Bew and Robert Lee. Whip mix articulator in three sizes: small, medium and large. Stoneberry tripod instrument designed without a hingle, no mechanical equipment or representation of condyles. A new articulator, an Archon instrument with no locking device. Meter interchangeable condylar paths, and the elements are adjustable in all three planes to accept our positional records. Now's model kinescope, double condylar posts on each side. Inner posts serve two purposes. They act as the horizontal condylar guides. Bennett angle is adjusted by rotating an eccentric cone. Pinky Man articulator. PMC philosophy. Part 1. Examination, diagnosis, treatment planning and prognosis. Part 2. Harmonization of the anterior guidance for best possible aesthetics, function and comfort. Part 3. Selection of an acceptable occlusal plane and restoration of the lower posterior occlusion in harmony with the anterior guidance in a manner that will not interfere with condylar guidance. Parts 4. Restoration of the upper posterior occlusion in harmony with the anterior guidance and condylar guidance. The functionally generated path technique is so closely allied with this part of the reconstruction. In class 4, this articulator accepts three-dimensional dynamic registration. They are capable of accurately reproducing the condylar pathway for each patient. They are type A, type B. Type A. Instruments in this class will accept three-dimensional dynamic registrations and utilize a phasebow transfer. The condylar pathways are formed by registration engraved by the patient. TMG articulator, Kenneth Swenson articulator. Stereograph articulator, TMG articulator. Type B, similar to type A and condylar pathway, can be selectively angled and customized. The procedure utilizes the pantographic tracking. Pantronic articulator, Denner by Denner. Gnatoscope by Charles Stewart and others. Denner model, D4A articulator. Simulator, fully adjustable articulators that can be set from pantographic tracking, positional records and other trackings. Based on theories of articulator, a Bonville theory articulator, conical theory articulator, Ria Hall, spherical theory articulator by Monson. based on the adjustability. 3 types: a non-adjustable, semi-adjustable, fully adjustable. Non-adjustable can open and close on a fixed horizontal axis, have a fixed condylar path, the incisional pins right on an inclined plate on a fixed inclination. Semi-adjustable have adjustable horizontal condylar path, adjustable lateral condylar path, adjustable incisional guide table, and adjustable intercondylar distance. 2 type: Archon type, non-Archon type. Fully adjustable, capable of being adjusted to follow the mandibular movement in all directions. They do not have a condylar guidance, instead they have receptacles. Steward gnatoscope simulator. Basic component of an articulator: as upper member, lower member, condylar track, condylar element, vertical rod, incisional guide table. Some commonly used articulator: mean value articulator, Hanna-White view articulator, whip mix articulator, Den articulator, Panadent articulator, TMG articulator. Mean value articulator: upper member, triangular frame, vertical rod with some screw, 2 condylar elements. Lower member, shaped frame with horizontal and vertical arm. Horizontal arm is triangular as its apex contains incisional guide table. Vertical arm is rectangular, contained condylar guidance slot at upper portion. Incisional guide table contain very short cylinder whose upper surface is concave. Vertical rod should rest on the center of the incisional guide table during articulation. Condylar guidance, represented by a slot, condylar track. Condylar element of upper member passes through this track. A spring is mounted within this track to establish the condylar element. Vertical rod of incisional pin helps to keep a fixed distance between the upper and lower member at anterior end. The pointed tip of vertical rod should rest on the center of incisional guide during articulation. Incisional guide pin present at the midpoint of vertical rod. The incisional edge of the maxillar incisors at the midline of the occlusal rim should touch the tip of incisional pin during articulation. It presents the anterior reference point. Now articulators, Hanna-White view articulators, Hanna-White view 2 articulators, Hanau H2 articulator, Hanau Archon articulator, Hanau radial shift. Hanau wide view articulator, semi-adjustable Archon type, accept the phase bow transfer, capable of hin and lateral movements. Upper member T-shaped with vertical and horizontal arm, condylar guidance attached to these. Mounting dowels present the center of undersurface, orbital indicator present near dowel. Lower member L-shaped with horizontal and vertical arm. Horizontal arm is rectangular metal strap. Dowel present center of the lower member, the mounting ring, and also a stand pivot. Vertical arm slope outward. Upper portion of vertical arm contain a roll pin which project on the other surface. The condylar shaft attached to inner surface of the vertical arm 20-30 mm anterior to the roll pin. The condylar element metal ball is attached to the free end of the condylar shaft. Condylar guidance. Its circular structure with a slot in the center. The condylar element of lower member articulate with this slot, also called condylar tract. The posterior end of this tract has a component known as centric stop. The condylar element should contact the centric stop during articulation. The condylar guidance can be rotated around the vertical axis to set the Bennett angle. Bennett angle H equal horizontal condylar inclination. Chisel guide table. It's a customized chisel guide table. The slope of the incisal guide table can be changed in the anterior-posterior direction and can lock in position with a lock nut. During articulation, it should be flat and the incisal pin should be at its center. A pair of lateral wings is present around it. Incisal pin. It's a double-sided pin. One end in a sharp but chisel-like with flat edge. The other end tapers to a pointed tip. Usually, the flat end is used. The incisal pin has series of markings closely placed in one end and two widely spaced markings in other end. The upper member of the articulator should be at the level of the darkest marking of the close marking. The spaced out marking acts as the anterior reference point in the absence of phase-bow transfer. Hanau's H2. Designed by Rudolf Hanau, it is an archon-type articulator. It has a fixed intercondylar distance of 110 mm and doesn't accept a phase-bow transfer. 4 different phase-bow can be utilized: fascia phase-bow, earpiece phase-bow, twirled phase-bow, adjustable axis phase-bow. Hanau radial shift. Structure is almost same as Hanau series articulator. It has right and left centric latches and the upper member is easily removed for waxing. The radial shift adjustment has a 3 mm radius and allow up to 3 mm of radial shift before intercepting pre-adjusted progressive Bennett angle. Hanau wide view 2. The only difference between Hanau wide view and Hanau wide view 2 is that the wide view has way closed condylar tract. The closed condylar tract doesn't allow the upper member to be removed, whereas the open condylar tract allows the upper member to be removed for waxing. Whip mix articulator designed by Dr. Charles Stewart. It's an archon articulator. The upper and lower member are mechanically attached by means of a spring latch assembly. The original modeling the condylar elements on the lower frame and adjustable to 3 positions: small, medium and large. Two different phase bows can utilized: quick mount or earpiece phase bow for complete denture, the adjustable axis for fixed prosthodontics. The intercondylar distance is determined from the scale on the phase bow, SML. The articulator has pins on the outer flanks on the condylar guides and corresponding holes on the medial side of the earpieces of the phase bow make for easy transfer of the phase bow record to the articulator. Modifications. Denner articulators, archon type. The articulator is a 2-piece instrument incorporating a positive locking mechanism that can hold the two members together by means of centric latch. The condylar elements are at a fixed 110 mm intercondylar distance. However, an adjustable distance 110 to 122 mm option is available. 4 types of face bow can be used: passive face bow, earpiece face bow, cybermatic face bow, adjustable axis face bow. The cinematic face bow has a feature of unique slide gear mechanism which make it easy and quick to assemble. The Mark II can be programmed using anatomic average positional records or with a mini recorder only. It's a newest than articulator. TMG articulator designed by Kenneth Swanson. The articulator has a spring-loaded latch to help return the upper frame to the centric relation position. There is curved incisional guide pin with both a plastic and adjustable mechanical incisional table. Small version of the articulator is available and is called the mini articulator. Its intercondylar distance is limited and has a straight incisional guide pin. Dentators. It's a shaft-type instrument. The condylar element attached to the upper member and the condylar path is straight. The intercondylar distance is fixed. The articulator received a angle axis face bow. The features are similar to a now model. Selection of an articulator. One shouldn't use too complex instruments for a simple case or too simple articulator for a complex case. The following factors pertain to the understanding and selections. Articulator movement of the condylar elements don't reproduce condylar movement in the temporomandibular joint. The goals of articulation is to duplicate tooth movements along border pathways in at least 2 planes of space. The most important requirements of an articulator are to maintain centric relation and the vertical dimension of occlusion. Fixed condylar elements at 110 mm are all that is necessary. An adjustable intercondylar capability may permit more records to be accepted. The articulator should be able to receive a face bow transfer record. The articulator should have the capability of adjustment for procurement of immediate side shift up to at least 2.5 mm. An adjustable mechanical incisional guide table cannot reproduce the natural guidance of anterior teeth. A stereograph pantograph has limited value for all but a few types of prosthodontics situation. The sophistication of articulators should not exceed the level of training and ability of the personnel that will be fabricating the restorations. Mounting procedure. Mounting of maxillary cast, mounting of mandibular cast. Mounting of maxillary cast. Maxillary cast is attached to the articulator using the orientation jaw relation record. Procedure of transferring the orientation jaw relation to the articulator is called face bow transfer. The earpiece of the face bow is attached to the row pin of the articulator. This transfers the posterior reference point of the face bow to the articulator. The anterior reference point should be positioned by making the orbital indicator contact the orbital pointer of the face bore. Pivot stand attached to the lower member of the articulator also helps to prevent vertical displacement of the occlusal rim during articulation. Mounting of mandibular casts. Tighten the centric lock on each enclosed condylar tract mechanism to ensure that the articulator is capable of nothing but a ink opening. Invert the articulator on the benchtop, resting it on the three thumb-nuts protruding from the upper member of the articulator. Place the centric relation interocclusal wax record on the teeth of maxillary cast. Be sure that the teeth sit completely into wax record. Place the mandibular cast into interocclusal record. There should be no contact between the maxillary and mandibular cast. Remove the mandibular cast and soak it for about 2 minutes in slurry water. Reseat the soaked mandibular cast into the record and mount it back plaster stone. Inspect the articulated cast. The condyle is in the retruded position in its condylar tract mechanism. Both casts are seated completely in the interocclusal wax record. Mounting stone is securely attached to both coasts and mounting plated. Conclusion. An articulator is an important device that mechanically analogs the temporomandibular joint and upper and lower dental arches. A device to which maxillary and mandibular casts can be attached with the intent of simulating the functional and parafunctional contact relationships of the arch to the other. Selection and arrangement of teeth for complete dentures. Introduction. After casts are mounted and occlusal scheme determined, maintenance of vertical dimension, anterior teeth primarily aesthetics, posterior teeth for mastication, harmony. Why selection and arrangement deserve special attention? Absence of periodontium, single unit on an unyielding base, necessity of bilateral balance, consequence of malocclusion, bearing of non-vertical forces, first molar and second premolar area, proprioception, incising with natural teeth. Review of literature. Anterior tooth selection. 1 size, 2 form, 3 shade, and 4 material. Size of anterior teeth. Size of face and head. Bizygomatic wide maxillary anteriors. Bizygomatic wide maxillary central. Length of face maxillary central. 10:1 ratio of cranial circumference to upper anterior teeth. Anatomical landmarks. Mark corners of mouth on wax occlusal rims, extension of parallel lines from lateral surface, ovala of nose onto maxillary occlusal rim, a line perpendicular to midline of palate through distal border of incisive papilla. Maxillomandibular relations, mandibular anteriors, class 2 and 3 arches, a contour of residual ridges, teeth placed to follow contour and size selected according to this position, vertical distance between ridges, lips, selection of length of maxillary anteriors. Highest point of upper lip when smiling, cervical necks lie at or above this line. If shorter teeth are selected, aesthetics compromised. High lip line. Nose. Distance between tips of canine is same as width of base of nose. Philtrum. Width of upper centrals approximates the width of philtrum. Pre-extraction records, facial photographs, diagnostic casts, radiographs, teeth of close relatives, extracted teeth. Form of anterior teeth, pre-extraction records, form and contour of face. Lyon-Williams classification, square tapering, void. Dentogenic concept, fresh and fisher densthetics. Sex factors, feminine softness, masculine boldness and hardness. Personality factor, vigorous type, medium type and delicate type. Age factor, incisional age, erosion, diastema, stippling of interdental papilla. Shade selection for anterior teeth. Shade selection along side of nose, basic hue, value and chroma. Under lips, only incisional edge exposed. Effect of color with mouth relaxed. Under lips, only cervical and covered smile. Use of squint test. Posterior tooth selection, size, form, shade. Size of posterior teeth, buccolingual wise, sufficient to act as a table to hold food, less than width of natural teeth, not to encroach on tongue space and buccal corridor, limits forces directed to reach. Mesodistal wise, a dentulous space available, placed as far as possible posteriorly, not over beginning of ascending area of ramus and retromolar pad. Occlusal gingival height determined by available inter-ridge space, occlusal plane and height of anterior teeth. Teeth with largest possible vertical width that can be used without grinding are preferred for aesthetics. Form of posterior teeth. Anatomic teeth, cusp teeth, simulate occlusal surface, varying degrees of inclinations. Standard is 33. Cusp incline is termed semi-anatomic teeth. Advantage, disadvantages. Non-anatomic teeth. Cuspless, non-monoplane or 0-degree teeth. offer less resistance to horizontal forces, bruxism, poor residual reach, uncoordinated muscular movements, more relationship of jaws class 2 and 3. Disadvantages: shearing efficiently, poor aesthetics, lateral and protrusive balance not possible. Shade of posterior teeth harmonize with the shade of the anterior teeth. Both influence the shade of teeth. Select a slightly lighter shade for the premolars. Selection of tooth material: resin, composite resin, acrylic resin, monolithic, cross-linked, IP and linked, porcelain, when aesthetics are paramount. Adequate interarch space is available. Resin and porcelain teeth, where potential, grinding and adjusting, bonding to denture base, version of opposing dentures, dentition, color stability, impact sound, rebasing, impact resistant. Posterior tooth forms, historical development. Tribute teeth by Gizi, channel tooth by Searles, metal insert in resin by Vincent, cross blades by Sosin. Non-anatomic teeth: inverted cusp tooth by Hall Sharp, concentric ridge around cup-like depressions. True cusp by Meyerson, buccolingual ridge with sliceways between them. Chopping block by Nelson, non-lock by Svensson, Italium occlusal by Hardy. Teeth arrangement: anatomical landmarks, ridge relation, balanced occlusion, neutral zone. Anatomical landmarks: residual ridge, position in relation to ridge due to resorptive pattern, arch form, square tapering, and void arch forms. Retromolar pad: too low an occlusal plane causes turn, beating, and too high a occlusal plane can cause instability and strain. Parotid duct: maxillary first molar, labial surface of canine, 10.40 mm, incisive papilla, midline, central incisor, perpendicular line. Teeth arrangement for class 1 ridge relation: wax rim contours, aid selection and setting. Occlusal vertical dimension: angulation of facial rims affects lip support, overjet. Place reference marks on the occlusion rims to aid in tooth selection and placement. Orientation of occlusion plane: occlusal plane upper rim anteriorly parallel to interpupillary line, posteriorly parallel to Camper's line. Power rim anteriorly lower lip, posteriorly half to and third retromolar pad. Central incisor: long axis parallel to the long axis of the patient face, the midline of the dental arch, the center of face, labial contour blend with the contour of face, rotation of long axis varies depending on arch form. Maxillary lateral incisor set at angle of 5 angle to the perpendicular. Incisal edge is about 1 mm short of the horizontal plane. Labial surface is inside at the cervical end. Distal half of rotated slide lingually. Canine: cervical end is more prominent labially Canine is the turning point of arch. Mesial half is harmony with the anteeth. Distal half harmony with post-teeth. Tip of cups is contact with the occlusal plane. Anterior teeth will generally follow the contours of the lower lip. Anterior teeth position incorrectly. This setup doesn't follow the contour of the lower lip. The lower anterior teeth. Central is the long axis parallel to vertical viewed from front. Sloped labially when viewed from side. Chisel edge 1 and 2 mm above the horizontal plane. Lateral incisor long axis parallel to the vertical viewed from the front. Slope labially. Canine long axis slightly leaned toward midline when viewed from front. Slightly lingually when viewed from side. Cusp is slightly above 1.2 mm above the horizontal plane. Canine K of occlusion. The distal incline of the lower canine should align with the mesial incline of the upper canine. Limits to placing anterior teeth. The mediolateral and anteroposterior position of maxillary and teeth limited by phonetics and aesthetics. Phonetics: long teeth F sound like V, S sounds too long, two tongue positions, palate, lower anterior teeth. For example, 66. Upper posterior teeth arrangement. First premolar long axis parallel to vertical axis when viewed from labial side. Palatal cusp is 1.2 mm slope of its buccal cusp from horizontal plane. Due consideration is given in aesthetics in female. Second premolar, both buccal and palatal cusps touch the occlusal plane. The first molar long axis slopes buccally when viewed distally from side. Mesolingual cusp. Molar K occlusion. The mesiobuccal cusp of the maxillary permanent molars should coincide with the mesiobuccal groove on the mandibular permanent molar. Second molar more inclined than first molar, cusps above horizontal plane. Maxillary teeth set checked on a flat plane. Lower posterior teeth. First premolar long axis parallel to the vertical axis. Lingual cusp is below the horizontal plane. Buccal cusp about 0.2 mm above occlusal plane. Second premolar long axis parallel to vertical axis. Both cusps are about 0.2 mm above the horizontal plane. The first molar long axis leans lingually when viewed from the front, mesially when viewed from the side. All the cusps are at a higher level above the horizontal plane than those of second premolar. Second molar more inclined than first molar, cusps above horizontal plane. Buccal corridor, spaced BV buccal surface of posterior teeth and inner surface of cheeks. Excessive buccal corridor results when posterior teeth are set too far lingually. Resulting dark space appears excessive and anesthetics. Inadequate buccal corridor occurred when posterior teeth are placed too far buccally, causing obliteration of buccal corridor. Teeth arrangement checked in patient mouth. Setup for class 2 and 3 cases. Setup in class 2 jaw relations. In this setting, the flattened lingual cusp of upper premolars occludes with the flattened buccal cusp of lower premolars, and a large buccal horizontal overlap occurs in the buccuspid area. Upper molars are set with their lingual cusp in the modified central cusp of the lower teeth. Posteriors should have eccentric occlusion with stable non-deflective stops. Set up in class 3 relation. If ridges are edge to edge, then anterior teeth are also placed edge to edge. In cases of extreme protrusion, negative or reverse horizontal overlap is used. A larger lower tooth mold can be used. Interchange of upper and lower teeth. First premolar may be eliminated from upper arch. Transverse ridges of upper posteriors are grinded away to eliminate mesodistal interlocking. Balanced occlusion. After centric balance is achieved, teeth arrangement is modified to achieve eccentric balance. At least a semi-adjustable articulator is required. For lateral balance, buccal cusps of posterior teeth should contact on working side, and on non-working side, contact should occur between mandibular buccal and maxillary palatal cusps. To develop balanced occlusion in protrusion, with the anterior teeth edge to edge, contact should simultaneously be established in the posterior teeth. Factors affecting balance. Condylar inclination cannot be altered. Incisal guidance can be manipulated limitedly. Cuspal inclination is determined by selection of teeth, so mainly the anterior-posterior curves P influence protrusive balance. Choose steeper as a condylar inclination. Steeper should be the compensating curve with low cuspal inclination to achieve protrusive balance while maintaining the centric contacts. Setup is neutral zone technique. Neutral zone is recorded, impression is indexed, teeth arrangement is guided by index, posterior teeth may require to be trimmed lingually so that they fit into index space. Polished surface of denture are also contoured to replicate record. Characterization. Subtle chips stains make teeth look more natural. Highest quality of art is to conceal art. Conclusion. Selection and arrangement of teeth is an art based upon biomechanical factors governing the ultimate success of dentures. Waxing and carving of complete dentures. Waxing is contouring of wax pattern of the wax base of trial denture into desired form. The polished surface, outer surface, which will be in contact with oral teeth, lip, cheek, and tongue, must be smooth and have natural details. This develops by contouring the wax. The form of polished surface of denture influence its retention quality, aesthetic values of the denture. The polished surface is determined by 1. The width of the border of the denture, the buccolingual position of artificial teeth, and 3. The fullness given to the wax to obtain convexity and concavity in the facial and lingual aspects. The inclined plane action of the muscles of cheek and tongue. This horizontal force exert in the direction of the occlusal plane by the tongue and cheek can act either and placing or displacing agent depending on the shape of the polished surface. When the lingual and buccal surface of a mandibular denture are being shaped, they can be made concave so that the tongue and cheek will grip and tend to seat the denture. In the opposite case, we in lingual and the buccal surface are made convex by waxing and a narrow impression base used. The inclined plane forces resulting from pressures of the tongue and cheeks will tend to unseat the denture. The buccolingual position of the teeth is important because the buccal position of the teeth would necessitate shaping the surface of the denture base in such a manner that the muscle action of the cheeks would tend to unset the mandibular denture. The buccal surface of the mandibular dentures in the first premolar region should be shaped carefully so as not to interfere with the action of the modulus connecting the facial muscles with the orbicularis oris. This connecting point of the muscles can display the mandibular denture if the polished surface inclines towards the cheek or if the arch in the premolar region is too wide. The wax surface around the teeth are known as the arch portion of the polished surface and should be aesthetic reasons imitate the form of the tissues around the natural teeth. Requirements of waxing the polished surface. They should duplicate the cover the soft tissues as accurately as possible, realistic, not exaggerate. The borders, both labial and buccal, should fool the vestibule. Knots should be provided to accommodate the mucous membrane attachment frenum, both in size and direction. The contour of the denture flanks should be compatible with the drape of cheek and lips. The contour of the lingual flanks should be compatible with the tongue. The palatal section of the maxillary denture should be nearly a reproduction of the patient palate and look. The procedure of waxing. Contour the wax carefully to prevent movement of teeth. Avoid a bulky wax up. The additional bulk of acrylic resin may contribute to porosity and dimensional processing error. Place strips of base plate wax along the face surface of the trained denture so that extend from the gingival third of the teeth to the edge of the cusp. With a hot spatula lute the strips to the underlying wax at 1/4 inch intervals and melt the wax into contact with necks of the teeth. After the wax has cooled, carve the interdental papilla. They vary with the age of patient. Develop the margin by the carving with an edge no 5 or Lacron carver at 45 angle and to the neck of the teeth. The posterior area should have a marked fullness. Wax the lingual flange on the mandible denture thickly enough to fool all depressions and to slope down from the necks of the teeth and invert towards the tongue. The slope of the flange should be free from the undercuts and very slightly concave at or near the lower border. Contour the wax around the necks or the maxillary posterior artificial teeth to form part of the clinical crowns and make these teeth more natural in size and more compatible to the tongue. The palatal surface of maxillary denture should be waxed to a uniform thickness or 2.5 mm when the processed resin is smooth and polished. The palate will be as thin as possible and yet sufficiently thick to provide adequate strength. Stippling of the wax. An alternative to gingival contouring, some people stipple the wax and this procedure a finished denture whose surface shows as orange peel effect. Produce a very pleasing result. This may be produced by taping the surface of the wax with the bristles of a toothbrush after first warming the surface, soften the wax, or by running over the surface of the wax with a small burnishing burr rotating in a hand piece. Disadvantage of stippling is that it produces a denture which is more liable to contamination by calcareous deposits. If done, it should be confined to the area of the denture which can be seen when the patient grins broadly. After the wax has been contoured, smooth it by flaming at the polished it with weak cotton. Establishing the posterior palatal seal. Establishing the posterior palatal seal. Posterior palatal seal area. It is the soft tissues along the region of the movable and non-movable part of the soft palates on which pressure within physiologic limits of the tissues can be applied by a denture to aid in the retention of the denture. The posterior border of the denture is determined in the mouth and its location is transferred onto the cast. The locations of right and left hamular notches are marked with an indelible pencil. Then the location of favea palatin near the median palate suture is marked. The vibrating line of the soft palate normally used as a guide to the ideal posterior border of the denture. It may be slightly posterior to the favea palatin. Procedure for carving of posterior palate seal area. A V-shaped groove 1 or 1.5 mm deep is carved into the cast at the location of the bit. A large sharp scraper is used to carve it, passing through the hamular notch and cross the palate of the casts. The groove will form a bit of the denture that provides the posterior palatal seal area. The bill will be 1.5 mm high and 1.5 wide at its base. Advantage of posterior palatal seal. It helps to determine the posterior border of maxillary denture. It helps to compensate for the shrinkage of the acrylic resin in this area during processing. Provide a good seal in this posterior area of the maxillary arch, which increase retention. It prevents food to enter under the maxillary denture, reduces the tendency for gag reflex. Identification of complete denture problem. A summary. Contents. Introduction. In this part we will discuss factors resulting in discomfort associated with dentures, factors resulting in looseness of the dentures, factors associated with problems of adaptation. Introduction. A list of factors resulting in discomfort related to the impression surface of dentures. Factors resulting in discomfort relating to occlusal and polished surfaces. Cheek and or lip beating, tongue beating, related polished surfaces, factors resulting in discomfort, factors with possible systemic associations, a looseness of dentures, factors resulting in a looseness of dentures arising from decreased retention factors, air burns the impression surface, xerostomia, neuromuscular control, factor resulting in looseness of dentures arising from increased displacing force, a list of denture problems associated with problems of adaptation, noise on eating, speaking, eating difficulties, blunt teeth, jaw closed too far, cannot open mouth wide enough for food, speech problems, gagging, appearance, too much visibility of teeth, creases at corners of mouth, natural color of denture base material. Conclusion. It's important to understand that our patients don't function like the static antithesis of impression materials or articulators. Complete dentures can be very rewarding through the use of proper procedures during fabrication and a clear understanding of post-insertion adjustment techniques. With a little time and focus, the prosthetics provided to the patient should provide years of satisfaction and aesthetic and functional enjoyment for the patient.